Good afternoon, and welcome to today's New York City Council hearing for the Committee on Mental Health, Disabilities, and Addiction. At this time, please silence all electronic devices. If you would like to testify, you must fill out a witness slip with one of the sergeant at arms. No one may approach the dais at any time. Chair, we are ready to begin.
Okay, great. Good afternoon, everyone. My name is Councilmember Linda Lee, Chair of New York City Council's Committee on Mental Health, Disabilities, and Addiction. Before we begin, I'd like to recognize that we are joined here by Council Members Caban, Botcher, our public advocate, Jumani Williams, I think that's it. Oh, Councilmember Mealy, who I think stepped out, and also Councilmember Hanif on Zoom. Today, the committee will discuss the Department of Health and Mental Hygiene systems for measuring outcomes and equity in city-funded mental health programs. Accurate, complete, and consistent data collection allows policymakers to assess whether programs are meeting their intended goals. Robust data collection and transparency not only helps to identify what's working and what isn't, but also ensures that resources are directed to programs that provide the greatest benefit to communities. When we talk about mental health specific programs, the evaluation of program outcomes is especially salient given the direct impact that these programs have on New Yorkers' lives. By systematically measuring outcomes and equity, we can make evidence-based decisions that improve accountability and ultimately strengthen the impact of mental health services across the city. Every improvement in a program's outcome is an improvement in someone's life, and it's our role as the City Council to make sure those results are reliable and transparent. I look forward to learning more about the ways that DOHMH evaluates programs in its mental health portfolio and the ways that the Council can continue to support and strengthen their program analysis and data collection. In closing, I want to thank the administration for being here today, as well as members of the public for taking the time to testify on this important topic. And I would also like to thank the committee staff who worked to prepare this hearing, as well as my own staff. And I'm just, personal note, I love this topic of data, so I'm actually really excited about this hearing. Not to sound a little nerdy on this, but I think data really does help us inform a picture of what's happening in the landscape of the city with our mental health program. So thank you so much for being here. And without further ado, I will pass the mic over to the public advocate.
Thank you, Madam Chair. I just want to make sure on the record, I say congratulations to the New York Knicks. They're the best team in the NBA today. So congratulations, us Knicks fans have had a great night. But oh, you saw the video? Yeah. I woke my wife up. Good afternoon. As mentioned, my name is Jumani Williams, public advocate for the City of New York. I'd like to thank Chair Lee and the members of the Committee on Mental Health, Disabilities, and Addiction for holding this important hearing. Almost 1 in 4 adult New Yorkers experience a mental health disorder in a given year. Mental illness affects people across all communities and demographics, wealthy and poor, young and old, black and white. But not everyone is able to access treatment, and not everyone who accesses treatment gets the kind of care they need. There are many reasons why New Yorkers who need mental health care either do not or are unable to access it, including cost, stigma, language barriers, and logistics. A report published this year by DOHMH found that in 2023, about 14% of New Yorkers, almost 1 million people, reported that they were at one time in the past year that they did not get the mental health treatment they needed. Many people face barriers accessing treatment because they do not have health insurance, which makes city resources all the more important, especially with Medicaid cuts looming. As is the case across the healthcare more broadly, Black, Brown, and Indigenous people fare worse when it comes to receiving effective mental health treatment. The vast majority of psychologists in the United States are white, and most offer services only in English. This can make it difficult for people of more color and immigrants to find a culturally competent provider, which has consequences, including misunderstandings, diagnosis, underdiagnosis, discrimination, and ultimately, ineffective and misguided treatment. One U.S. Surgeon General report found that people of more color experience a greater burden of disability from mental illness, more likely to suffer from prolonged, chronic, and severely debilitating depression that affect their daily lives, compared with their white counterparts, because they often receive less care and poorer quality care. The reasons why mental health professionals are disproportionately white are varied and complex, but include a historical racism in the mental health field and the high cost of the higher education required to enter the field. The federal government's recent announcement that nursing, social work, and other public health fields are no longer designated as professional degrees, quote unquote, and thus ineligible for a higher limit on federal student loans will only raise the financial barrier to graduate education for prospective health workers. During this time when, quote unquote, DEI has become a cultural flashpoint, and efforts to increase diversity in various fields are being undermined or entirely eliminated. We must step up to ensure that our mental health care workforce is diverse not only in identity but in experience. LGBTQ plus people in New York and across the country, especially trans people, are under threat by this presidential administration. The LGBTQ plus community and transgender people in particular are at higher risk for suicidal thoughts and suicide attempts, with 40% of transgender adults having attempted suicide in their lifetime. With growing barriers to gender-affirming care, we will likely see that number increase. A brief from DOHMH published this year reported that the prevalence of serious psychological distress, SPD, was higher among LGBTQ plus New Yorkers than their heterosexual counterparts, while transgender adults were 2 to 3 times more likely to experience SPD than cisgender adults. Those who hold multiple marginalized identities like queer and or trans people of more color may experience even more heightened stress. Last month, my office released 2025 update to our original 2019 report, Improving New York City's Responses to Individuals in Mental Health Crisis, which we also updated in 2022. In it, we acknowledge that where the city has improved in its availability of resources for those in crisis, but there are too many places where we must and can do more. We tend to focus on the moment a person is in crisis and meets the system, but we also must dedicate resources far before that happens, when young people are considered whether they wish to pursue a career in the mental health field. Scholarship and loan forgiveness programs, creating jobs that pay a living wage, and expanding training opportunities for peers to work in mental health will encourage additional people of more color and those with lived experience to pursue this as their career and lend their unique perspectives and talents to the people of New York City. Looking forward to hearing the data as well, seeing how we can improve care. Thank you.
Thank you, Public Advocate. And on that note, I totally fully support those statements, because in a lot of the work that we did in my former role as a nonprofit leader, it was frustrating because we often couldn't send our constituents and community members to services where they would receive, in language services or culturally competent services. And part of it was we need to help build that pipeline and make sure that they're looking at these careers. I know when I told my parents I wanted to go to social work school, they're like, what? What's that? So I have to, we have to educate our own communities and make sure that we're creating a pathway to them that's affordable as well, so that they can get wages as well. So thank you for those statements. And I'll now turn the mic to the Community Council to administer the oath to members of the administration.
Now, in accordance with the rules of the council, I will administer the affirmation to the witnesses from the mayoral administration. Please raise your right hand. Do you affirm to tell the truth, the whole truth, and nothing but the truth in your testimony before this committee, and to respond honestly to council member questions? Okay. Thank you. Prior to delivering your testimony, please state your name and title for the record, and you may begin when ready.
Good afternoon. Can you hear me okay?
Yes.
Excellent. Good afternoon, Chair Lee and members of the committee. I am Dr. Gene Wright, Executive Deputy Commissioner for the Division of Mental Hygiene at the New York City Department of Health and Mental Hygiene, the Health Department. I am joined today by Jamie Nichols, Assistant Commissioner for the Bureau of Mental Health, and Dr. Rebecca Lynn Walton, Assistant Commissioner for the Bureau of Alcohol and Drug Use. Thank you for the opportunity to testify today. The Health Department recognizes that the mental health and well-being are central overall health. The Mental Health Division puts this into action by employing a public health approach to supporting the mental health and behavioral health of all New Yorkers. We serve as the city's mental health strategist and work with more than 200 community providers to deliver over 800 mental health programs. First, I'd like to share our vision for mental health for New York City, which shapes our desired outcomes, divisional strategy, and day-to-day operations. A public health approach to mental health aspires to a future where every single New Yorker lives with dignity and meaning. Everyone has access to the resources they need to thrive, to live, and to live their full potential. New Yorkers understand the importance of mental health, have access to services they need, and know how to access them, and where New Yorkers are free from stigma, oppression, and the consequent health disparities. The Health Department is organized around this ultimate vision. I want to uplift what Acting Health Commissioner Dr. Morris shared in her recent testimony on Healthy NYC, the city's campaign for improving life expectancy. Most New Yorkers did not live to see their 50th birthday when the health department first started calculating life expectancy in the early 1900s. Today, our latest data shows that New Yorkers can expect to live into their 80s. Transformation has happened and remains possible, especially when there's support for public health infrastructure. I'll now turn to our work today in Mental Health Division. The Health Department is the city's mental health strategist. We stand at the nexus of the city's mental health system, serving as a linkage between the state, the city, hospitals, providers, peers, communities, and experts. We provide decision makers and the public with population health data on mental health outcomes, paired with guidance and collaboration and acting on it. First and foremost, we look to health outcomes to measure the well-being of our communities and inform program strategy. For example, Healthy NYC identified key drivers of life expectancy, including 2 mental health outcomes: suicide deaths and drug overdose deaths. The Health Department developed ambitious goals to reduce both drivers and closely monitor progress in these outcomes. Suicide is one of the top 10 leading causes of premature death. After a slight reduction in the suicide rate in 2018 to 2019, rates climbed during the COVID-19 pandemic. Provisional data for 2023 and 2024 show a slight decrease, a 2.5% decrease compared to year 2021, showing a return to the previous levels. Overall, suicide rates remain mostly level over the long term. We are committed to our goal of reaching a 10% reduction by the year 2030. Regarding overdose, our most recent data shows progress with reduction in drug overdose deaths. Following years of increases that cost New York City nearly 20,000 lives since 2016, the number of overdose deaths decreased by 28% in 2024. Residents of all 5 boroughs saw decreases. While significant racial and geographic inequities persist, overall deaths decreased among Black and Latino New Yorkers for the first time since 2018. This information is essential for understanding the health of New Yorkers and guiding our programmatic investments. Our mental health programs are diverse, ranging from direct services to systems change interventions. We identify unique outcomes for each program to measure service quality, impact, and successful program implementation. For example, the Intensive Mobile Treatment, or IMT program, was created almost 10 years ago because we saw an unmet need and responded with innovation. IMT serves individuals with high service needs that are not being met in traditional mental health outpatient settings. IMT consists of teams working in the community to provide long-term support to people with serious behavioral health concerns and complex life situations that may include transient living situations and housing instability and/or involvement in the criminal legal system. Stable housing is a program outcome we monitor in IMT because many referred individuals are unhoused at the time of enrollment. In fiscal year 25, the proportion of those stably housed increased by 23%, the first and most recent year of enrollment. Individuals referred to IMT often have a history of involvement in the criminal legal system, so this is another key program outcome we monitor. IMT teams provide support to prevent participants' further involvement. Among IMT participants served in fiscal year 25, the proportion of those with jail admissions in the New York City Department of Corrections system decreased by 5% between pre-enrollment and the most recent year of enrollment. If we look at supportive housing, the program outcomes are different. The mission of supportive housing is to provide dignified, safe, and affordable housing as a platform for health and recovery. While we monitor aspects of service quality and tenant outcomes, the number of supportive housing units available in itself is a critical program outcome. We currently contract for 12,817 units of supportive housing and are on track for 13,000 units by the end of the calendar year. Lastly, I'd like to highlight the outreach and syringe litter teams. These teams conduct outreach to people who use drugs in public in order to provide naloxone and connect people to treatment, health care, and resources to meet their basic needs. They also respond to community concerns of syringe litter. There are currently 6 teams operated by 5 contracted syringe service programs. In 2024, these teams cleaned up and safely disposed of more than 199,000 syringes, initiated over 25,500 participant engagements, and made more than 8,000 referrals to additional care services. To expand on this work, soon all 16 syringe service providers in the city will have outreach and syringe litter teams. I've highlighted a handful of the 800+ mental health programs we support to illustrate the thoughtful, evidence-based approach to measuring success we employ for each unique program. Across all programs, equity is always a critical consideration and desired outcome. Health equity is central to our vision for mental health in the city. Thank you so much. We recognize that historic and contemporary injustices in government, healthcare, and other institutions have deepened distrust and contributed to individual and collective trauma, while exacerbating inequities across health conditions. We aim to eliminate inequities in mental health outcomes. The Health Department is dedicated to supporting the mental health and behavioral health of all New Yorkers. I am proud to share these impressive outcomes today and pleased with the progress we have made. We look forward to continually improving our programs, expanding our partnerships, and embracing our supports for New Yorkers in the greatest need. We welcome feedback from Council and community members today as we continue to improve and adapt the city's mental health infrastructure to better meet the needs of New Yorkers. Thank you for the opportunity to testify. My colleagues and I look forward to answering your questions.
Quick question. Did you want to go over some of these numbers in the appendix, or I wasn't sure. Or maybe it's hard to put on the screen, right? Yeah, okay, never mind. Because they're very, okay,
Yeah, Chair.
either way, oh, as needed, okay. Okay, so I think, first of all, thank you for this information, and I think, in general, I'm going to just ask a few questions about what defines success and impact and how you measure those things across different programs and if there's any standardization, because I think, as you all know, one of the things I've talked about in previous hearings is how oftentimes it's hard to track data because not all of it is collected in the same way, or not all of the measurements are the same across different programs depending on what they are. And so really quickly, in the first question, so this is very broad. How does DOHMH currently define success and impact across the mental health programs it funds? And what core outcome metrics are standardized agency-wide?
Thank you for the question, Chair. The Health Department is committed to protecting and promoting mental health for all New Yorkers. Our vision for mental health for the city is ultimately to have all New Yorkers receive the treatment and services they need, and that's the success we're striving for. At the day-to-day programs we held in the city, the Health Department and division-specific standards, we all use a measure to impact success. So the divisions may use a difference, a bureau may use a difference in the Health Department and the city. So the programs are very unique and very specialized, and so they may have different ways of measuring. At a minimum, every city human services contractor receives a passport contract rating. This serves as a baseline measure of success in service delivery. And my colleagues can give you more detailed information across the bureaus that they represent, but also the programs that they evaluate.
And is there a specific, like if you can give examples of like the basic demographics that you usually ask for across all the different programs, that'd be great too.
Yeah, absolutely. Can we start with the Bureau of Mental Health, and then we'll go to that? Thank you.
Yeah, sure. So for all of our programs, we're collecting information about the volume of work provided, right? We need to understand that we're like the city is contracting, purchasing, right, the delivery of human services. So we're going to keep track of the volume of people served and characteristics of those folks coming in. So we're looking at gender, gender identity, race and ethnicity, as well as age group. Those are the most common measures that we're looking at among programs where we have that information. There are some programs that are really high volume. For example, NYC 988, we had a hearing about that a couple months ago, right? We wouldn't have that sort of demographic information on every person who calls. It's not practical to collect. But on other programs where there is more direct, person level contact. We're collecting that sort of demographic information on everybody who comes in. And then some information about the services that they receive, right, based on the intention of the program. Is it a rehabilitation program focused on education and employment goals? We're going to look at that. Is it focused on housing stability? We're going to look at that. Is it about de-escalation in the community? We're going to look at that. And then some level of disposition, right? So referrals in, characteristics of the people in, what they're getting, tailored to the program type, and then the disposition or the outcome, right? What is it? On a crisis intervention, where, for example, mobile crisis, we're going to want to understand to what extent the crisis is de-escalated and the person remains in the community safely. In a housing program, following periods of chronic homelessness, we're going to want to measure whether the person stays in the housing program. And in an IMT program, for example, focused on highly transient folks who are homeless but also moving around a lot and have criminal legal involvement, we're focused on attaining housing stability and reduced criminal legal involvement. So it's really tailored to the intention of the program type.
Okay. And then even in the programs that you just mentioned, are there proactively data sets that you're asking for? For example, even if I'm going into the housing program, maybe there's some other, for example, domestic violence or gender-based violence situation that I'm facing, which is the root of the trauma of why I'm homeless, right? So are those things also being asked proactively, even though it may not necessarily fit into the bucket, but are there ways to get to that information as well that are proactively being asked as well?
Sure. So that question, I don't know if you mean it generally or specifically, but there's a very specific answer. So our housing units, for example, Dr. Wright talked about almost 13,000 units. They're focus on various specialized populations. One of them is families who are in shelter and victims of intimate partner violence. So there's a subset of our units for whom that is the entirety of the population. So we know that's essentially their qualifying criteria for entering into the program. And then the services provided are sensitive to that trauma experience.
Okay. Oh, go ahead. Sorry.
I mean, the only thing I'd add to that is I think part of it is always that balance that I'm sure was your balance also in nonprofit is how much are we collecting versus how much are we prioritizing time with the individual. And so we try to really make sure that the data we're collecting is on that program and the programmatic goals so we can show that it was effective. But we certainly do a lot of things like training. And last week I was part of an outreach team summit for all of the contracted vendors we work with, and we're continuing to do that. And they brought up things like training for things that they didn't know about when they came into that service. And so I think in that way, it may not be data we're providing, but it's technical assistance and training so that people are getting that response, whether or not it makes it into an Excel spreadsheet, for example.
Okay. Good to know. And I know that the council recently passed a data disaggregation bill, which is something that folks in the community have been working on for a while, because oftentimes, for example, when you say Asian, there's a lot of ethnicities within that group. And so, because I remember being part of a meeting with a previous health commissioner, not this one, where we were looking at maps of chronic diseases across New York City. And the population breakdown ethnically was Black, White, Latino, Other. And this wasn't that long ago. And so I know that there have been a lot of changes and strides made to be more, diverse in how we're categorizing some of these populations. And so just wanted to see, how is that being broken down in terms of ethnic population or age group? And is it consistent across all the different DOHMH programs? And is there a sort of standard of, how you're measuring that?
So we have more specificity in the race and ethnicity data that we're collecting than your previous experience. So we're looking at non-Hispanic Black, non-Hispanic White, Asian American, Native Hawaiian, Pacific Islander, Hispanic, and unknown are the most common categories that we're collecting. And then we do look at that upon for all the people that we're serving, right? So of those who we're serving, what are the race and ethnicities? But then also for the outcome of the program, measuring looking at whether those outcomes are experienced by people equally across gender identities, race and ethnicity, and age, for example.
Okay. And what systems or platforms do you use to collect, store, and analyze mental health program data? And what gaps or limitations exist in the systems as well?
I'm happy to start this one off. Yeah, so when people think about what are people doing at the health department, a lot of our funding goes to community providers, and then the bodies in the chairs analyzing the data. That's often combing together and adding together a lot of, we can't ask all of our nonprofit providers to be able to afford very expensive platforms. So we have a wide variety, and we're stitching it together so that we can better tell the story of the programs going on. And so we have analysts. We also do a lot of cross-bureau work so that we're making sure how is our data that we're receiving from syringe service programs where people are also involved in supportive housing, and how is that speaking to one another. And a lot of our improvement projects have come out of things like that and better wanting to understand how people are experiencing across programs. So a lot of stitching together of disparate platforms. There's probably think of like 10 off the top of my head that are used across programs, but that's part of the job of the health department, is to be able to then share that back to the programs as well.
Got it. And are there certain barriers, like when you're first getting all that incoming data, do you physically have to yourselves sort of input and then also, like you said, stitch it across? Or are you looking into certain platforms or AI or tech or something that will actually help organize or better analyze some of that data? Because I'd be curious to see how that would look, only because, one of my things also is there's so many silos, and even within the different program areas, there's a lot of silos. And so, like you said, I'm curious to see how, if you were to break that down, what maybe how the story would look different for someone from your perspective in terms of how to better serve some of the community members.
I think one piece that's important is that we have community advisory boards as well. And so that's another place where we can check that story against what community members are experiencing. I think, yes, we're always looking for technology. There's definitely people who have a lot more expertise than I do as a social worker in that, and so we definitely rely on them. But also our teams are incredibly well steeped in how to stitch that data together. So I think they're constantly thinking about how, and we work with our state partners and other city agencies, and it's really a conversation that's ongoing and can absolutely always improve.
Yeah, I couldn't agree more. And there's, you asked about AI. Our agency has a really clear policy for use of AI, and our research and evaluation staff are using it to check code, to write a data check, and there's a sort of a whole-scale data integration, effort across the agency, right? We're talking about mental health here, and there's other parts of the health department as well. So that work is underway.
Okay, perfect. And then in terms of quality of data, because I'm sure that, again, people are reporting things perhaps differently or not as consistently. And so how are you ensuring the data quality and consistency across the contracted providers that you work with, who may use themselves very different internal data collection systems?
Yeah, so as we said before, we have over 800 programs, and so that's quite a bit. And we have, that's just in mental health. And so we have the ecosystem of data analysts, as Rebecca mentioned, researchers, epidemiologists within our division, And these folks are really, their job is to make sure that the core infrastructure, the data that is brought in is brought in. We have the Center for Population Health Data that helps us coordinate all of that across the whole agency. And as Jamie and Rebecca said, we can always improve, but that is a central focus for the health department, is how we collect data, the quality of the data, and then making sure that the programs within our division specifically are able to share that in ways that are, if it's feasible and if it's permissible and if it's something that is useful, we're able to do that in a meaningful way. But that Center for Population Health Data is really helpful. But it's, again, it's ongoing. It's something that we're going to continue to move towards. So thank you.
And what is your process for evaluating whether a program with poor or unclear outcomes should be redesigned, scaled down, or discontinued? What does that process look like?
So I think we can speak to the bureau level, then I can give you an overall view as well.
Yeah, sure. So we're looking at the overall contract rating that Dr. Wright mentioned earlier, right? The passport rating, excellent, good, satisfactory, poor, unsatisfactory, right? Those are just very broad terms for use across human service contracts citywide. If a program is given an unsatisfactory, if a contract is given that unsatisfactory rating, that's likely to be a contract that we do not renew, right? Where does that unsatisfactory or poor rating come from, right? That's all the work that our teams do. So our contracts require providers to report in all timely and accurate data. They enter it into data systems. We look at their outcomes. We also visit all of our programs at least once a year on site, announced and unannounced visits to spot check their own data systems to make sure it sort of aligns with the data they're reporting to us, to speak to their staff, to speak to their consumers, to understand what's causing the problems and try to fix it, right? We're not looking to just immediately end a contract, right? We want to provide technical assistance, understand what's causing the challenges to the service delivery, provide technical assistance, training, extra support where we can to improve that care, because these are providers who know their communities, have relationships with clients. We want to support that. Ultimately, if that technical assistance doesn't work, right, and we need to request a corrective action plan, we'll do that, give providers time to make improvements. And if that's still unsuccessful, right, you'll get that unsatisfactory passport rating, and we can discontinue contracts, which we do from time to time.
Yeah. So you guys work, I'm assuming, with mocks on that, right? To make sure. Okay.
Yep.
And how often does DOHMH conduct internal audits, which we all love, of reported program data? And what are the most common discrepancies or challenges uncovered during those audits, just out of curiosity?
Yeah, I can answer on the bureau level. I mean, so it can be something as simple as like a not formal audit, but saying, hey, I noticed your data, it said you had a participant who's 250 years old. Maybe that was a typo. And so, that's how we're looking into it, to make sure that the data is correct, and knowing that there's error. And so we always are coming from a place of trying to check with someone. And so that's where those, weekly conversations with programs and monthly and visits. And I know I've been out to lots and lots of places in the year and a half I've been here, and it's really important work. But I think I would say all of that does fit into audits, because we want to make sure that we're helping people be successful and have the resources they need, and give them a chance to correct things if maybe they do have a 250-year-old participant, and then we will have met all of our Healthy NYC goals. So that's great.
Yep, that would be that would be a flag, yes. And how do you ensure that community feedback, including from clients and families, because I feel like it's always important to have their voices at the table. So how do you ensure the community feedback is integrated into the evaluation of the mental health programs? Is that something you integrate into some of the outcomes, or?
Sure. Thank you, Chair. Definitely, we get a lot of feedback from our community service boards and also our satisfaction surveys. And I know we have a broad variety of how that takes place, again, at the bureau level. And so each of our ACs can speak to that, but we have a lot of feedback from the community in those three areas as well. So maybe break down how it works in each of your divisions would be helpful.
Sure. So contracted providers conduct consumer satisfaction surveys, right, of their programs directly with their consumers. Our staff, when we go out and do these visits, we meet with program participants. We also convene a community services board where we have representatives from various geographic and experiential and programmatic disciplines to speak to us directly. We have youth and adult advisory boards as well, consumers that come and speak to us directly. And then when we always establish the outcome measures in the procurement process, right? We release a concept paper, we get public feedback to that, we issue an RFP, and the measures of success for that program are specified really clearly in that RFP. And we get lots of public feedback on those concept papers and RFPs as well, so to make sure that we're sort of establishing the best measures.
I think the only thing I'd add to that is the importance of having people with lived experience at every part of the health department. I think we have one of the largest peer workforces I'm aware of, but it's also important to understand that there's even barriers for people accessing that certification. So we want to make sure we have both those formalized mental health and substance use peers, but also really recognizing the importance of all types of lived experience. And I don't think there's any part of the bureau of the agency where I'm not aware of people talking about their lived experience to inform the work.
That's great that you guys have that staffing within the department that have lived experience as well, because that's going to be key in informing some of the strategies and programs. So that's great to hear. Okay, I'll take a quick break from myself. And Councilmember Botcher, do you have questions you wanted to ask?
Good afternoon. I want to ask about staffing shortages and unfilled positions in the department. You have so many great programs, both on the government side and on the nonprofit side. Are there unfilled staffing positions within these programs? And if so, how many? And has that affected your ability to collect and analyze data as we're discussing today?
Thank you for the question, Council Member. Certainly, work vacancies are always a challenge across, not just for us, but across the board for all city agencies and, frankly, even the private sector. I'm happy to report, though, that we have the right amount of people in the essential positions that we have to make sure that these evaluations and gathering of data, like I mentioned, the epidemiologists, the researchers, the analysts, to do their jobs. We certainly are open to any help we can have in filling those positions, but they have not, to this point, caused us to lose anything in terms of our ability to evaluate or analyze programs or the quality of programs. And in terms of the specifics of your question, again, we have differences at the bureau level that certainly my colleagues can speak to, but I'm very comfortable with the fact that we're able to do our jobs with the staff that we have.
With respect to mental health programs, where are the vacancies? Where are the most unfilled positions?
I think, again, it's going to be different across, but I would start with maybe social workers.
Or maybe just move the
I'm
mic
sorry,
a little bit
I said
closer.
it's probably going to be different
Pull it
across.
right in.
Closer, is that better? All right. I said that I think it's going to be different again across our whole division, but I would say that what I've seen, social workers is a key number, but I would leave it to my colleagues to speak for their bureaus in terms of the challenges that they're seeing. But across the board, I would say social workers.
Yeah, I think workforce turnover is a challenge. It's better than it was during the pandemic, so I can tell you that much. It's not as bad as it once was, but there's periodic turnover across all of our program types: housing, crisis, treatment, care coordination. Typically, we find those jobs that require travel, right? Visiting people across the city are harder to fill than others. They're physically demanding. Where do you go to the bathroom, right? Those things. Where do you have lunch? Those are challenges when you're 100% mobile treatment. You have an office to go back to, but it's grueling work. We attempt to compensate that, right? Higher salary sometimes for these positions, but we're competing against like a telehealth job, right? That's our hardest positions.
With respect to since this hearing is about data and reporting, how are you analyzing those shortages across the mental health continuum? How are you reporting them publicly? How do we get a handle on where the shortages are and the best strategies to fill them?
It's a great question. Thank you, Council Member. I know that in our division of Bureau of Management that we keep track. This is specific to mental health. Keep track of the vacancies and across which bureaus and what positions that those vacancies occur. And so we do have the ability to track those vacancies and what the challenges are. We're able to talk to the ACs and ask them where they're seeing the biggest challenges in their bureaus and what we can do to help support getting those folks hired and getting those positions filled. And so it's a very organized process.
I know a big focus of the incoming administration is going to be filling vacancies. So we look forward to partnering with you in that effort.
Absolutely. Thank you, Council Member.
Awesome. Thank you, Council Member. Okay, so switching gears more about specific programs and data collection. For programs like clubhouses, intensive mobile treatment IMT, or assertive community treatment ACT programs, how does DOHMH measure reductions in psychiatric hospitalizations, justice involvement, homelessness, and crisis episodes? And I know there's a lot in that question, so.
That one's me. Yeah, so I spoke a little bit earlier about the measures we collect across all program types, right? People served, the race, ethnicity, characteristics of them, how long they're in the program, the benefits, and the outcomes they achieve related to their enrollment in the program. So I'll take I think you had named 3 different program types. So for clubhouses, for example, that intervention is designed to provide psychosocial rehabilitation services, helping people develop skills related to education, employment, and living a satisfying life. So we're measuring, first of all, active participation in the clubhouse, right? Because it's a membership for life model. So we can't just sort of anybody who ever enrolled, we can't reasonably call them a member forever, right? We'd have a cumulative account for 40 years. And so we're measuring how much time people are exposed to the intervention, essentially, right? So we now know for the first time ever, we've never known this, 30 years of contracts, that people go to clubhouses on average 5 days a month. In person, 1 day virtually. So that's important for us to understand the sort of the amount of the intervention they're getting associated with the outcomes that it's designed to provide. So education and employment are really important goals of Clubhouse services. Participating in the operating of the Clubhouse is designed to build skills that will transfer to employment. And so I'm excited that we have, for the first time ever, the outcome data to report on the 13 clubhouses that we have in contract with us. Of those who are interested in employment, right? Not everybody's interested in employment. For example, if you're of retirement age, you may not be interested in employment, right? If you're in school, you may not be interested in employment. But of those who are interested in employment, I'm going to read it here so I get it right. The proportion of those employed increased by 24 percentage points, from 31% in enrollment to 55% at the end of last fiscal year. That's a huge increase in employment. And then we look at that, we stratify by race to understand if those gains were experienced by all groups. So we looked at it and we see API Clubhouse members had higher rates of employment to begin with, less gain over time. Hispanic and Latino identifying folks, as well as non-Hispanic Black folks, also saw the greatest gains in that employment. So that's one way that we're able to use the data to understand if our impact is equitably experienced across all groups. That's Clubhouse. You had some others. Do you want me to?
Yeah, just yes. IMT, ACT, and then also in terms of the justice involvement, is there a partnership with corrections or DOJ when it comes to looking at recidivism, or if there are other measures like that that are sort of showing that someone is receiving the help and if these programs are being effective?
Yes. So I'll take for IMT, right? In that program, we are aiming to increase housing stability and reduce jail time. And so we have New York City Department of Corrections data to match with the identifying information we have for people in IMT. And so also, I got to read these ones. I don't have them all committed to memory. We can see that among those folks who were served in IMT last fiscal year, so FY25, the proportion of those with jail admissions decreased by 5 percentage points between pre-IMT, pre-enrollment, and the most current year. Right, so that's exactly the result that we'd like to see among this population. We're also looking at housing attainment for that IMT group. We're seeing even greater benefit there, showing that among those served in FY25, the proportion of those stably housed increased by 23 percentage points. And stably housed, we defined as stably as housed for 6 consecutive months or longer, right? And this is pulling from a group that's 100% housing transient, right? That is a qualifying criteria. So achieving that level of housing stability among that many people is extraordinary.
And according to this chart, do you think the supportive housing grow? I see that it's it's grown in FY25, but is it growing at the rate that you think is meeting the population's needs?
There will never be enough supportive housing in our city or affordable housing.
Yep.
So no, it's never enough. We have an affordability crisis, and so people with mental illness and substance use disorders are no different than any other New Yorker. They're struggling to find affordable places to live. But the supports that we bring to those affordable apartments are really valuable, and they're growing. So we're on track. That's an MMR indicator, and we're meeting that indicator. We're at I just got a count this morning, 12,998. I was really hoping it would be 13,000 for this hearing, but I'm too off that number.
Too off.
Yeah.
We'll get there. Okay, perfect. And let's see, sorry. And what data does DOHMH collect from providers of community-based organizations receiving funding through the mental health initiatives, and how is the data validated?
I can start us on that. That's what I talked about before when we get data from folks and we're checking are there outliers? We're doing quality assessments, and we're really trying to figure out at a bureau level. I know I'm also focused on how people are going between different programs. For example, the harm reduction programs, people have been in treatment programs before. They may go back to treatment. They may go to the recovery centers. And so some of the analysis we're doing and working with the programs to be able, because some of what we're talking about is actually a full academic evaluation. So we also have academic partners who can do those long-term multi-million-dollar outcome evaluations to demonstrate impact. And so we're incredibly grateful to have their expertise for that, because that's all they're doing is working on things like that. But then how do we tell on the sort of day-to-day level that people are, and that was the summit that I mentioned before. I mean, I know it's not data analysis, but it's gathering people in a room to talk about how they're connecting with one another, and is there a way for them to better share connections between the organizations. Also, we work very closely with DHS, for example, and we had a meeting recently about, we were talking about people being unhoused in a different way they were. So we kept saying, why are we finding differences in how many people are unhoused in this certain area? And so by having shared language around how we're classifying or identifying people as housing needs and what the different interventions are for it, we were able to better understand what the true experience of the people we're serving are.
And how do you count those folks that are sort of in and out? You know, if they're the same person, are they being double counted, or how are you tracking or following someone through their recovery or through the different services that they use?
I think the short answer is there's always going to be double counting, but the good news about that is that each time they receive a service, that's what we're contracting for, and so that's how we pay nonprofits. So maybe they are being seen at both DSS services and our services, or maybe both in a recovery center and a harm reduction program, but they did receive, it's sort of like when I go to my endocrinologist and I go to my PCP, and so they're both paid for it because they're both doing different things. And so that's, again, where if we want to know how one person goes through the system, that's those outcome evaluations. But if we want to see what is the scope of the work we're doing, that tends to be more of what was provided to the person.
Yeah, and I just wonder how that would track differently depending on what question you want to answer, I guess, right? Because the number of units is the number of units, which is good to know either way. But then I guess the question would be if we want to actually understand and know better how or if someone is receiving certain services and then coming back less, right? Like how do we track that and see if they're making improvements? So I guess I'm just wondering for those types of information or data that you're looking for, how would that like how would you approach that differently in terms of what you're looking at in terms of data sets?
Did you want to? You can go. Yeah, I mean, so one thing that we've been looking at is over time, for example, fewer people have been coming for methadone services. And so to counter that, knowing that people still need access to medication for opioid use disorder, how do we bump up the access to buprenorphine in other settings? There's fewer restrictions. And so that's one way that we're using data to inform, are we doing the right types of services? And that's where a lot of the opioid settlement funds going to the syringe services programs to have mental health and substance use support and wraparound. That's where the data definitely informs exactly what we're doing for New Yorkers to make sure those same number of people are served where they ultimately want to be served in the way they want to. I don't know, Jamie, if you have.
Yeah, the only part that I was going to add to that is how specific it can be. So it may not be that we want, for every population, we want more care or less care, right? Let's take housing, for example, where average length of stay is about 8 years, right? In the first year a person moves into an apartment from a period of street homelessness, we would expect more care, right? They've come inside, they may be going to the hospital more, maybe going to their healthcare providers, and that's good because there was a period of time where they weren't interacting at all. So we might see higher utilization of expensive and valuable and essential healthcare services. And then over time, 5 years later, 10 years later, we would expect to see something different. So we really have to think about the context, right? The individual, the focus of the population, where that person is in their lifetime, their age, their recovery journey, et cetera, to understand what, in fact, do we want more or less of this particular indicator?
Yeah, and I guess to that point, how do your systems allow for or maybe limit? I don't know how robust it is internally within DOHMH, but if you were to look at different data sets and dissect them differently, to look at different outcomes, how easy is that for you guys to do? I know.
I mean, this consumes our lives, right? This is what we do. I'm so excited to talk with you about it. It's really hard.
Yeah.
And we do it all day, every day. And we've got massive, time and expertise devoted to it. But it's not simple, right? Humans are really complicated. And this city is especially complicated, right? And you combine those things, it's hard.
Yeah. And actually, this is going to something that you had mentioned before, about coordinating with other agencies, sort of, because I love talking about how we can sort of better communicate between city agencies to get a better picture and understanding of what's happening. And so how do you coordinate with other agencies? This is going more so to the terms and conditions. How do you coordinate when the terms and conditions required shared data, joint reporting, or cross-agency program tracking? Because I know that sometimes it differs, sometimes significantly across different agencies, depending on what you're asking for. So when the terms and conditions happen, how do you coordinate with other agencies?
Thank you for your question, Chair. The terms and conditions from the Health Department for the I'm sorry about my voice, for the FY26 budget do not actually pertain to the Division of Mental Health. But so I can't speak to those specific reporting requirements. As an agency, we adhere to all council reports, and we are required to do our due diligence to provide information. And so we take that very seriously. But specific to our division, we do not have that requirement in terms of the mental health.
Okay. Which health-related performance measures are tracked for DOHMH in the citywide performance report? And how do they reflect the agency's effectiveness in promoting public health?
I can do this one. So it's units of supportive housing and death from unintentional overdose.
Okay, wait, those are the main two? The only,
Those are the two indicators we report for the citywide performance report, the two
Got it,
mental health
okay.
indicators, or behavioral health. Excuse me.
okay.
Yeah, and I think we also report on things like buprenorphine. We can follow up with the exact list.
Okay, perfect.
It was the MMR. Sorry about that.
Oh, MMR, yeah. I know, there's a lot of different acronyms here. Actually, so let's go to the PMMR and the MMR. So which performance indicators in the PMMR and MMR provide insight into the effectiveness of DOHMH-funded mental health and behavioral health programs?
Yeah, so this is where we get in to the BUP. I'll let you, Dr. Lynn Walton, talk about that. But I think we're talking about in the PMMR and the MMR, we have people monitored by our assisted outpatient treatment program, right? So that's Kendra's Law, or AOT, the supportive housing, as we have in the other report. Health-led crisis responses and community-based de-escalations. Those are referrals to mobile crisis teams, right? Teams of peers and social workers that keep people safely in the community and avoid hospitalization. And as well as those contacted by our co-response teams, right? Similar idea, to keep people in the community, avoid police interactions and hospitalizations. And finally, on the mental health side are those engaged in our long-term treatment services, that ACT and FACT and SPACT, those services. So we're reporting on all those measures in the PMMR and MMR, of course.
Okay. And how can trends in the PMMR data help identify emerging challenges or areas needing improvement in mental health and behavioral health services?
I mean, the MMR, it's every 4 months, right?
Yeah.
And it's a little bit of a lag. I wouldn't say that's where you're going to get sort of emerging trends, frankly. It's not that real time. So those are sort of the biggest picture sort of numbers that we can represent our work through. I don't know if you want to add.
Yeah, I also think change takes more time sometimes than that time frame, and so that's where our annual reports come in, and we're really trying to track both those short-term outcomes. Are we doing the things we said we would, and then what's happening over time? For example, I always think of the example that we had a 50% reduction in overdose deaths last year in Staten Island, and we immediately were like, what is going on, and how do we do that everywhere? And we were looking at BUP uptake, and they've been doing a tremendously successful job in getting people connected and then staying on buprenorphine. And so that's my assignment for the year, is figuring out both how to continue that and then how to do that elsewhere, or if something else is needed elsewhere, how to still do what's needed elsewhere.
Right. Okay.
I think additionally, Chair, in the fall, we had a suggestion from the committee, the council, to add 988 as an indicator. And so thank you for that suggestion, and we're going to be adding that in. And so we'll be able to report on that under Jamie's bureau. And so thank you for the suggestion. And
That's awesome.
That's
good to
a
hear.
positive move.
Yeah, that's awesome.
Yeah, I forgot that one. Thank you. Because it had been there years ago, and it came out for a year and a half, and I misspoke in our last hearing. I thought it was still there. But it'll be back in. And just keep in mind that it's a different way of counting than it was in the past. I spoke about that the last time a little bit. So the numbers, it won't be like a continuous impression. We'll start sort of fresh.
Got it. Which, by the way, when I'm randomly in different spaces where we're talking about mental health issues, I ask people randomly in the audience to raise their hand if they know what 988 is, and a lot of them still have no idea. So it's great because then I'm using those opportunities obviously as a way to spread the word about it. But I was like, wow, I can't believe we need to just, we still need to get it out there. But yes. Okay. And in terms of comptroller audits, one of the I can start with this one. Yeah. Okay. So one of the key recommendations of the comptroller's audit of the citywide doula initiative specifically was to supplement incomplete programmatic data by matching CDI clients to more complete data sets such as Medicaid data, and that would allow the agency to compare outcomes between individuals that received doula support and those that did not. And so has DOHMH considered applying this approach and how it evaluates its other programs?
Thank you for your question, Chair. The Health Department is always looking for ways to strengthen how we evaluate our programs and how we include, the data and and so we're exploring these opportunities. To your question, yes, we are exploring these opportunities, and where appropriate and feasible, we are considering linking program data with broader health and administrative data sets. And we want to improve our understanding of the health outcomes. And so these approaches are evaluated on a program by program basis. And so we certainly are taking all this into consideration.
Perfect. And I think you sort of spoke to this before in terms of the client information or input, but another recommendation that emerged from that report was the need to incorporate client satisfaction surveys into the data collection process to analyze the differences in satisfaction between vendors. So I know that you had mentioned earlier that you're doing some of this incorporation into your programs, and so just wanted to see if there were further comments based on the comptroller's report.
Yeah, I think both ACs can speak to the satisfaction surveys in their bureau, and maybe even across the overall community service boards.
Yeah, absolutely. We have all of our contracts are doing consumer satisfaction surveys, right? There could be some standardization of that tool, although some providers, may want tools that reflect their communities and their organization's mission. So it's hard to. We have to balance both of those, right? The value of the citywide data and also the specificity and experience of our CBO partners.
Okay, perfect. And also in the comptroller's audit of the IMT program, the issue was raised that DOHMH does not verify and review whether the client data reported to the agency by providers is accurate and supported by client case files collected by the providers. Does DOHMH have any plans to assess and evaluate the accuracy of the data submitted to the agency by the third party? Or, yeah.
Yeah, so I can speak to that. The comptroller, audited, I think it was a period of like 2016 to 2023 of IMT. In 2016, 2017, 2018, there were 75 people enrolled in IMT. It was the demonstration project. It was very tiny at that time, and we had just invented it. There were no structures because we were testing out an innovative idea. And then it went well. We re-procured it for the first time. It was a demonstration project, and we expanded it up to about 800 spots at that time during FY 20 and 21 in New York City, which, as most of us remember, was the pandemic. So yeah, there were some I's that were not dotted and some T's that were not crossed during a period of rapid growth of a really innovative model. So I own that, and we are working on that. The model has flexibility by design, and so we want to preserve that flexibility, and at the same time recognize the need to sort of ensure that our providers are held accountable, right, for the funding that we're providing for them to do this really important work. And so we have a data reporting system. I cited a lot of the outcomes earlier in responding to the Q&A based on that data, and we've added a team of folks to go out, a couple folks to be newly hired in the coming year to spot check some of the actual data entry points that the providers put into our data systems, which was the feedback from the comptroller.
Okay, great. And in the report, I think they also touched upon some of the CAPs, the corrective action plans. And were most of those from the periods during COVID, or was it just, is this in general, or can you speak to that a little bit in terms of the process and implementation of the corrective action plans?
Yeah, so it was during the period, that I just described, which included most growth during the pandemic. And so we have updated our program guidelines, first of all, which we do periodically anyway. They include all of our program types, including IMT, and clarified the requirements around corrective action plans so that improvement was made for the IMT programs as well as all of our other contracted programs, and that's in place.
Okay, and then the last question I had about the comptroller's report specifically is just related to the uniform reporting template for its program specialists to ensure the complete and consistent collection of programmatic data. I think at the time, DOHMH responded that it would improve consistency in the documentation of program reviews. And what is the status of this recommendation, and does it apply to the agency's other programs? And I guess one other thing I would add is it possible to do that given the difference in all these different programs? So I know that the report can say one thing, but then I guess what I would like to know is, in your opinion, whether it is doable or in the best interest of some of these programs to have. I mean, I know we talked about certain things being consistent, right, in terms of uniform reporting, but just wanted to hear your thoughts on that.
Yeah, thanks, and I appreciate the nuance in your question, right? Because it is really challenging, and what we've done, and I described it in parts of my answers already, right? We have the citywide passport sort of rating criteria, and we've adopted that rating criteria for our own program reviews, right? So every, there's a contract with a program, the requirements. We have guidelines by program type. Those are shared with providers. They have it. I'm happy to share that with you. It's got a chat, guidelines that apply to all programs, and then subsequent chapters that are specific to program types, because it won't be the same exactly for every program. We visit one program every year, conduct a review, provide written feedback. This is the template. We're with that feedback, giving a rating that aligns with the passport rating to be more clear, right? Was this rather than sort of a list, just a list of like problem, right? It's like overall satisfactory program. Here's a few things that could use improvement. Some of those are small, some of them are big, right? Depending on the program. And so we've standardized the sort of the language to use that same passport skill, so that we're giving a provider a heads up, right? This is how, it's like a mid-year report card essentially, right? This is how it's looking, right? Let's improve it so that at the end of the year, you get a satisfactory passport rating. Otherwise, if there's an open PIP, that's going to be reflected in your passport rating. So some standardization in that sort of top line feedback, but allowing room for nuance beyond, because there's so many different program types.
Yeah, I was going to say, because just knowing all the programs you have, it's like when I sit here and think about how you would consistently uniform some of that reporting, it would be, I would imagine, very challenging. So, but obviously appreciate all the efforts that you guys are doing to make sure that it is there. And just a couple more questions about the IMT and ACT programs. And if you, I know that some of the funding is definitely new and probably is still being worked out with the IMT that we provided, for example. But in the FY26 budget, the City Council secured $4.5 million to establish a step-down pilot program for ACT and IMT clients. And what is the current status of this RFP, and what is the timeline or in anticipation of releasing the RFP?
Absolutely, we appreciate the council's interest in these programs. We have to defer to OMB on the details of the specifics. Those are still under review. Step down's hugely important, though. We couldn't agree more. There's a variety of programs out there doing this work that we value. They're essential to our city. We have our Connect clinics that are receiving step downs. There's a flexible ACT model, and the state is developed, right, to expand ACT caseloads to help with step downs, and there's some innovative ideas out there as well from our nonprofit sector. So we love all of the above, and we're talking with OMB about the details of that funding.
Yes, that's like I always joked that when I was in nonprofit, OMB is like the Wizard of Oz. Like I know someone's behind there pulling the levers, I just don't know who. But yes, hopefully it'll get decided soon. And what is the status of the $11 million the City Council secured to expand IMT teams? Or is this sort of basically the same answer where it's related to OMB? All rolled in. Okay. So hopefully we will get some clarity on that whenever, you have the opportunity or chance to. That'd be great. Okay. I think that is it. That's it on my part for questions. And I just want to say publicly for the record, obviously we were entering into a new session on the council side. We have no idea where we're going to land in terms of committees. If I stay here, great, we get to work together for another 4 years. But if I don't, I just wanted to publicly say thank you for your partnership in this work. And I'm definitely not going away either way, because I still want to work on these ideas that we have. But I just wanted to say thank you so much for your partnership in this work. So thank you.
Thank you.
Thank you very much, Chair.
Okay, so while you guys are transitioning out, I'll just read the statement on the next part, which is going to be around public testimony. So just wanted to open the hearing right now for public testimony. I want to remind members of the public that this is a government proceeding and that decorum shall be observed at all times. As such, members of the public shall remain silent at all times. The witness table is reserved for people who wish to testify. No video recording or photography is allowed from the witness table. Furthermore, members of the public may not present audio or video recordings as testimony, but may submit transcripts of such recordings to the Sergeant at Arms for inclusion in the hearing record. If you wish to speak at today's hearing, please fill out an appearance card with the Sergeant at Arms and wait to be recognized. When recognized, you will have 3 minutes to speak on today's oversight topic. If you have a written statement or additional written testimony you wish to submit for the record, please provide a copy of that testimony to the Sergeant at Arms. You may also email written testimony to testimony@council.nyc.gov within 72 hours of this hearing. Audio and video recordings will not be accepted. And I say this at every hearing, but believe me when I say our committee staff are amazing and they literally read every single word of the public testimonies that get submitted. So we will definitely take all of your feedback into consideration. And so now I want to call the first in-person panel. We have Yuna Yoon, Sofina Tani, and Zarin Yakubi. So if you guys can come up to the dais, the desk. Also, did you guys have a fourth person, or is it just the three of you for your panel? Three? Okay, perfect. And feel free to begin whenever you're ready.
All right. Hello. Can everyone hear me? Okay. Thank you, Chair Linda Lee and the committee members for providing us with the opportunity to testify. My name is Sofina Tani, and I'm the Senior Program Coordinator at the Asian American Federation. And we're here to testify as part of the AF's Asian American Mental Health Roundtable, which is a coalition of 15 Asian-led, Asian-serving organizations that advocate for increased access to culturally competent mental health care. So when evaluating city-funded mental health programs, it's essential that the Departments of Health and Mental Hygiene value both quantitative and qualitative data. While numbers help us understand reach, they don't capture the depth or complexity of care our communities need. Across our roundtable, providers report that Asian New Yorkers are presenting increasingly severe and layered mental health challenges, often related to financial instability, family conflict, trauma, and isolation. Supporting clients through these experiences requires trauma-informed, culturally competent, and time-intensive care that can't be fully reflected through just numerical metrics alone. For many Asian New Yorkers, healing takes a lot of time. Progress sometimes looks like reduced stigma, stronger family relationships, simply the ability to even seek help. So these qualitative outcomes reflect meaningful impact and should be recognized as valid measures of success. Without them, evaluation systems risk overlooking the real work that's happening on the ground. When outcome measures fail to reflect the intensity and cultural responsiveness of services, they limit our ability to advocate for policies and funding that truly meet our community's needs. Clear and inclusive evaluation standards ensure that Asian communities are visible in the data and that city-funded programs are assessed in ways that advance equity. So we urge the Council to consider the following recommendation. Number 1, incorporate equal emphasis on qualitative outcomes when assessing program success, not just numerical outputs. Number 2, evaluate programs based on depth of support, especially for immigrant communities facing cultural, linguistic, and systemic barriers. Number 3, reduce reporting requirements to allow organizations to dedicate more staff time to direct services, especially for communities requiring trauma-informed and time-intensive support. Number 4, providing a transparent outline of how program success will be measured, including required outcomes, reporting expectations, and evaluation metrics so that organizations can plan data collection, build appropriate infrastructure, and accurately track outcomes. And finally, offer capacity building workshops and host ongoing office hours on program evaluations for smaller Asian-led CBOs, ensuring that they have the tools and the guidance needed to meet reporting expectations without being disproportionately burdened. Thank you for the opportunity to testify. More information will be found in our written testimony, and we look forward to working with you all.
Great, thank you.
Okay. Hi, everyone. Thank you, Chair Linda Lee and members of the Committee on Mental Health, Disabilities, and Addiction for holding this hearing and providing us with the opportunity to testify. My name is Yuna Yoon, and I'm a director at the New York State Motors Mental Health Clinic at KCS, where we provide clinical and psychiatric services and a host of other programming incorporating community psychoeducation, family therapy, art therapy, and more. We are here testifying as part of AAF's Mental Health, Asian American Mental Health Roundtable. I'd like to start off with a brief vignette. When we interview clinicians, as expected, they bring up the market value for their position if they were to work in institutional settings or in private practice. However, when we can only provide a nonprofit rate, our current staff have all mentioned that they would like to work at KCS because they want to serve Korean and immigrant clients, knowing the barriers they face and the lack of access to trauma-informed, culturally responsive support in their own language. This is rare. Our providers are the bedrock of our clinic, and we want to make sure that their work is sustainable and that they're financially secure and not have to feel they're sacrificing their own well-being and financial safety over their clients. Our experience with delivering services and matching them to grant reporting requirements directly matches the points that AAF raised. Our providers truly care and provide meaningful care grounded in relationships that they build with clients, something that cannot be expressed in numbers. We see the progress in the full spectrum of needs that are met. Children who don't readily communicate finally opening up through art therapy and eventually engaging in family therapy. Individuals and couples becoming better aware and able to care for themselves and others. Those with severe mental illness, gambling, and substance use issues mandated to counseling. Suicidal clients and new clients discharged from psychiatric facilities. All of them have come through our doors and left better equipped to handle their challenges and connected to a wide array of other social services and community supports. This work takes much time, tremendous dedication, and teamwork. We were notified yesterday that our OMH clinic was recertified, a process occurring every 3 years, but due to COVID, happened in 6 years. The intensive documentation process for OMH clinics, in addition to all the reporting for city discretionary grants, requires buy-in from all our staff, including fee-for-service staff who work other full-time jobs. KCS remains committed to providing equitable, culturally competent care. These are but a few examples of why we need evaluation systems that value qualitative outcomes and the intensive nature of this work. Thank you for the opportunity to testify today.
Thank you. Go ahead.
Good afternoon, Chair Lee and members of the Committee on Mental Health, Disabilities, and Addiction. My name is Zareen Yakubi, and I serve as a mental health clinician at Arab American Family Support Center, otherwise known as AAFFC. We provide linguistically accessible, trauma-informed, and multi-generational social services to New Yorkers all across the city. And we particularly have expertise in serving the growing Arab, Middle Eastern, North African, Muslim, and South Asian communities. As members of AAF's Asian American Mental Health Roundtable, we are here today to underscore the urgent mental health needs of New York City's Pan-Asian and immigrant communities and to emphasize the importance of valuing both qualitative and quantitative data when evaluating city-funded mental health programs. While quantitative data shows how many people are served, qualitative data shows how our services actually impact people's lives. It captures our clients' real experiences and shows that healing and progress cannot always be measured by numbers alone. And at this moment, qualitative data makes clear that our community members are struggling profoundly. Cuts to vital social safety net programs, coupled with increasingly punitive immigration enforcement measures, have created immediate and deeply felt threats to family unity, economic stability, and overall well-being. Every day, our staff witness pervasive fear and anxiety among our clients. Families delay or withdraw from essential services despite urgent needs, and parents are fearful of sending their children to school. Community members avoid medical care and hesitate to report violence, abuse, or exploitation. These realities are not easily quantified, but they are deeply consequential. And the impact to our community mental health status has been profound. Demand for mental health services at our agencies have surged by more than 80% at the beginning of this year and have continued to grow exponentially. And while this data point is important, the context behind it is even more telling. Individuals are seeking care amid compounding crises, prolonged uncertainty, and sustained trauma when they are culturally competent and linguistically accessible to them. We urge the Council and the Department of Mental Health and Hygiene to consider the following recommendations: to incorporate equal emphasis on qualitative outcomes alongside quantitative metrics when assessing a program success. Evaluate programs based on the depth of quality of support provided, particularly for immigrant communities facing cultural, linguistic, and systemic barriers. Reduce the administrative and reporting burden so organizations can dedicate more time to direct trauma-informed services. And lastly, to provide a clear and transparent framework outlining how program success will be measured, including required outcomes, reporting expectations, and evaluation metrics. City-funded mental health programs must be evaluated in ways that truly advance equitable outcomes for immigrant New Yorkers. Thank you for your time.
Thank you. And if you have not submitted the written testimonies, definitely submit them if you haven't already. So, okay. Thank you, everyone, especially for the work you guys are doing in the community. I know it's not easy, so we appreciate you all. Thank you. Okay. The second in-person panel, Dr. Van Yu, Bridget Callaghan, Paula Magnus, and Irvin Dana Beal. Sure, whichever order.
Sorry about that. Good afternoon, Chairperson Lee. My name is Dr. Van Yu. I'm the Chief Medical Officer of the Center for Urban Community Services, CUCS, and its healthcare affiliate, Janney Medical Care. CUCS operates 8 intensive mobile treatment teams serving more than 200 New Yorkers who, because they have been unable to engage in sustained relationships with traditional providers, have fallen through the cracks of our mental health, housing, and criminal justice systems. IMT works because we prioritize relationships over everything else. By building trust and nurturing relationships over time, we create the safety participants need to engage in care and to start to build new lives. Our outcomes demonstrate this model works. In November 2025 alone, IMT psychiatrists conducted 133 visits with 116 participants and provided 226 medication prescriptions to 61 participants. Our participants demonstrate 72% medication adherence for schizophrenia, 57% adherence to medication-assisted treatment for opiate use disorder, which is compared to 25% nationally for unhoused populations, and 57% utilization of long-acting injectable medications for psychotic disorders compared to just 4% nationally. Let me give you one example. Mr. C is a man in his early 50s with a long history of trauma, substance use, and debilitating medical conditions. He was referred to us with frequent emergency service utilization and a history of street homelessness. He was initially aggressive with the team, including throwing hot coffee at the team members on one occasion. However, through repeated outreach and nearly daily visits, he developed trust and became willing to accept care, including medications. His alcohol use has decreased significantly, his physical health has improved, and ER utilization has significantly decreased. The cost effectiveness of IMT is striking. Our program costs about $44,000 per participant annually. compare that to a 2-week psychiatric hospitalization at about $25,000, or incarceration at Rikers at about $507,000 per year. Additionally, the kind of healthcare service costs that go into these programs are remarkably efficient. For example, street medicine costs about $2,400 per day, which amounts to about $410 per patient visit, while primary care costs $1,600 per day, or about $250 per patient visit. When you consider that we are preventing the costly crises that have defined these individuals' lives, the value is clear. So, IMT is proven effective and cost-effective, but to scale what works and address disparities, we need to access more comprehensive data. I want to acknowledge that DOHMH has taken steps to share data providers have been entering for 8 years, and we really appreciate this progress. However, there are significant delays in receiving housing retention data, housing placement data, and psychiatric hospitalization data. And some other kinds of data are lacking, all of which could be used to both improve the IMT model and also demonstrate IMT's impact on the healthcare system. I'll stop there. Thanks a lot. We'll be submitting.
You can finish up.
Okay,
sorry.
great.
Yeah.
Thanks. Comparative and longitudinal data and data about trends in different populations could shape and improve staff training, address disparities, and guide utilization of effective interventions. Here are 3 things that could be helpful. First, access to data on days incarcerated, days hospitalized, ER visits, and arrests before IMT and after connection to IMT. Second, access to data in Maven that allows us to see relationships between service provided and outcomes, controlling for demographics, diagnoses, and settings. Third, real-time dashboard tracking hospitalizations, incarcerations, ER visits, and relationships between these outcomes and factors like race, gender, diagnosis, and housing type. With the Council's oversight and DOHMH's commitment, we can ensure that city-funded mental health programs have the support and data needed to keep improving and delivering equitable, effective care to our most vulnerable New Yorkers. Thank you. We'll be submitting written testimony
Okay,
also.
perfect.
Thanks.
Thank you. And go ahead. Yes. Hi. How are you?
Good. My name is Dana Beal. I've testified to you before. I'm here representing ACT UP. I might note that the AIDS Coalition to Unleash Power had to agitate for 10 years to get effective medications for HIV/AIDS. The advent of nerve growth promoters, such as Ibogaine, completely changes the calculus of public health and the treatment of substance abuse. It will save New York money at every step. We, the Research Access Working Group of New York ACT UP, acknowledge that New Yorkers with financial resources are already accessing Ibogaine in Mexico, Costa Rica, and Brazil, being treated for a week or 2 and coming home clean. While these programs can cost the patients from $5,000 to $12,000, we could do it here for about $2,000 per patient. Ibogaine researchers have found that for opioid substance use disorder, 50% of the Ibogaine patients are able to stay opioid-free for 6 months after treatment. This is phenomenal compared to NA, peer support, Suboxone, and methadone. The cost of lifetime medication is canceled. For cocaine and methamphetamine, the only conventional pharmacotherapy is Wellbutrin, effective for only 1 in 10. Adding naltrexone increases that 2% to 12%. Since Ibogaine regenerates dopamine neurons directly, the numbers for psychostimulants are a bit better than 50%. A bonus is that about 50% also recover from their need to use alcohol and tobacco, a leading cause of death and a huge social and law enforcement problem. This is a hospital procedure requiring medical supervision during the acute phase, about 2 to 3 days. Patients must be screened for pre-existing conditions and any other meds before treatment. Additionally, because the treatment is swift, it frees up their bed for other treatments after a week, unlike the 90-day treatment model for other detox rehab programs. This is a gigantic gift to our economy and social service systems. Nonviolent drug offenders clog our courts, fill our jails, and resist efforts to modify their behavior. Addictions are a mighty driver of social problems and a public health nightmare. People who use IV drugs also spread Hep C and HIV. They are more likely to do so if they cycle in and out of jail. The other principal vector of HIV transmission is chemsex with crystal meth. During their lifetimes, people with HIV generally cost our healthcare system and Medicaid programs about $500,000 per patient. If the patient's HIV diagnosis is delayed for 3 years, perhaps because our HIV prevention budget was just cut, that number jumps to $1 million. We believe that offering addicts this additional therapy option will meaningfully reduce transmission of HIV and total HIV healthcare costs. In addition, this is extremely important, among people with psychiatric disorders, ibogaine often also resolves the underlying problems that are driving substance abuse and homelessness, such as bipolar disorder, which is extremely effective for. In addition, the cost of keeping nonviolent offenders in jail is astronomical. What if we could offer a diversion program in the form of an ibogaine treatment option? The Department of Corrections has 3 hospitals, all rehabbed and ready to go, that are not being used for Rikers patients because of staffing issues. What if the Bellevue facility at 462 First Avenue was transferred to DOH-MH so that people under court supervision, as well as the general public, could benefit from this medical breakthrough? That 100 beds could provide treatment for up to 5,200 people a year, 1 a week. More than enough to address the treatment shortfall that's keeping us from closing Rikers. Let's support an ibogaine drug treatment diversion option through the establishment of a clinic with the oversight of doctors from Columbia University with a background in this type of therapy. I also might add, your aide, John Wanney, has a draft of a bill that we're trying to get you or Eric or somebody to introduce. There are several different ways of proceeding, however. We could do the Rikers alternative, or we could do an overdose prevention center that is ibogaine oriented.
So those, yeah, I can definitely.
When can we meet with you personally?
Yeah. So I think John, is he here? He may have stepped out, but yeah, we'll set up a time to have that conversation. Because also, I mean, without going into details, even if we have a bill in the pipeline, it doesn't mean it's always going to get introduced. So we'll talk about that offline.
Okay, thank you.
Thank you. Just wanted to recognize we've been joined by Councilmember Abreu. And also, Bridget, you're just on time. Thank you. Go ahead.
That's generous. I think that I'm late, and I very much apologize for that. Good afternoon, Chairperson Lee and members of the committee. Thank you for the opportunity to testify. My name is Bridget Callahan. I'm the Vice President of Intensive Mobile Treatment Programs at the Institute for Community Living, otherwise known as ICL. ICL supports New Yorkers with complex behavioral health needs through housing, healthcare, and recovery services, reaching about 13,000 people each year across more than 140 programs in New York City. First, thank you, Chair Lee, for your leadership, accessibility, and deep commitment to equity and to New Yorkers who are struggling. Today's hearing is about how DOH-MH evaluates outcomes and equity, and I want to underscore both what's working and what needs to improve. ICL's intensive mobile treatment and our innovative first-of-its-kind step-down program STEPS are models of distinction for reaching the most acute, hardest-to-engage New Yorkers. People have often been spent decades on the streets and cycling through shelters, hospitals, and other crisis systems. IMT meets people where they are and stays with them through instability. Across ICL's 6 IMT teams, 92% are connected to care. Housing increased from 40% at the time of referral to now 83% of our folks are currently housed. Medication adherence rise to 68%. And in the last 6 months, 93% avoided a mental health related emergency room visit or inpatient hospitalization. 98% had no criminal justice involvement. That's it for my data. To sustain and strengthen these outcomes, we need clear and regular IMT reporting. Our teams submit detailed data to DOHMH every month through the Maven system, but providers don't get the compiled information back. Because of this, we can't track trends, identify inequities, or use the data for continuous learning and quality improvement. We urge DOHMH to match what's done for the state's ACT program. ACT data is reported and shared publicly through an OMH dashboard that teams can review and learn from. IMT deserves the same level of transparency. Providers like ICL also already generate data regularly, sharing it back and publicly reporting it would strengthen accountability, support equity, and improve outcomes across the system. Finally, we want to thank the City Council for securing critical fiscal year 26 investments, $11 million for IMT and $4.5 million for related intensive services. We're eager to see these funds procured and deployed so we can expand access to IMT and ACT step-down programs. Thank you.
Thank you. That was a good summary of what you submitted. Yeah. No, I appreciate it. Thank you. Okay. Thank you all for this panel. And then, oh yeah, we're going to move to the Zoom remote testimony. So thank you so much. Oh, okay. I think so. Okay, we will now move to Zoom testimony. Please wait for your name to be called to testify and select unmute when prompted. And so far, we only have one person on Zoom. It's Christopher Leon Johnson. If you're there. Oh, there you are. Yes. So feel free to start. Oh, wait.
Yeah, hello. My name is Christopher Leon Johnson. Thank you, Chair Lee, for being a great chair for the past 2 years as the mental health chair. I know you'll be reappointed as a chair of the Menace administration, so don't worry about that. But I want to I know that in next session, there's going to be a more moderate approach to the city council, which will make people believe in the government again, as the city council be at official check and balance to our incoming mayor, Zoran Madani. But what I request in the next session is that the city council, starting with the Committee on Mental Health, Disability, and Addiction, have a joint hearing with DYCD and public safety when it comes to the cure violence organizations in the city, because they're taking all this money for mental health outreach and nothing is getting accomplished. All this is what they're doing is they just line their pockets up with the money while you still have the violence that's going on in the communities. Look, I think you heard what happened in Sandy Nurse District, where 6 people got shot outside a Sweet 16 party. Now, cure violence nonprofits like Brownville Think Tank Matters and Elite Learners, and what's the other one that Chris Banks worked with? I think it's like a TMK, something like that. TMK, I think Hood. They get all that money from these cure violence for mental health, and this stuff is still going on. So I believe that you, as chair, Mr. Lee, need to start having request a hearing from Menon, and I'm gonna ask Menon to do this in the next session, to have a special hearing and start asking these cure violence nonprofits, all these executive directors, y'all get all that money for mental health outreach. What are y'all doing with the money? Because the violence is still going on in the communities. People still get shot and killed. People still getting traumatized by these shootings, to where the point that they want to eradicate ShotSpotter so they can line their pockets up. So I'm calling you, Mrs. Linda Lee. I mean, I'm going to do this myself when she becomes speaker, when she gets sworn on the 7th, the day after. I'm going to make that request to the speaker, Menon, that she has a special hearing and have these and subpoena all these nonprofits to come out and testify and ask, like, where this money is going. But I want to end this right here to say that, like I said, that's basically when that's my request. I think a lot of these other organizations that was out there speaking today, they hit it on the money. Like they need funding, they do need funding, and and I'm not against that. But what I want, like I said before, these cure violence nonprofits gotta be called out because nothing's getting accomplished. It's just a grift. And what it does, and I know we have few seconds left, is that all it does is that it divides the community from the nonprofit, and then it helps divide the community from the government, and it really lowers the trust between community and the government. And I think we know in the past 4 years under this speaker, Jane Adams, she dropped the ball. She dropped the ball heavily.
Thank you
And
so much. Your time has expired.
Hello.
Yeah, if you could just wrap up in a couple sentences, that'd be great.
So all this does is just divides the community from the government, and I believe that I think I see Sean Bray did next to you. Shout out to Sean Bray, who does great work. He gonna keep his spot too as the sanitation chair. But like I said, I hope next year that Mrs. Menon as a speaker and you, Linda Lee, and Sean Bray come together and help rebuild that trust between people, this community, and the city council. That starts with, especially in the inner districts, that start with calling these corrupt, cure violence nonprofits, especially the ones I just mentioned. So thank you and enjoy your day.
Great, thank you.
Thank you. Thank you.
Great. Okay. So we have Paula Magnus. Sorry, because we called you earlier, but I think yes, sorry about that. But yes, not to rush you, but whenever you're ready, feel free. And then let me just call a couple names: Grace Nichols, Alex Stein. I'm not sure if you guys are on Zoom. If you are, please raise your hand.
My apologies. Thank you so much, Chairperson Lee and esteemed committee for, of course, convening this critical, important hearing. I'm Paula Magnus, the Deputy Director of Northside Center for Child Development. For over 75 years, we provided comprehensive evidence-based trauma-informed mental health services to children and family in Harlem and surrounding boroughs. We currently operate 2 city council-funded programs contracted with DOHMH. Based on our experience, we offer 3 observations: consistency of engagement, tracking treatment, contacts is valuable for children under 5, and therapeutic contacts that build secure attachment, of course, is extremely important. For our court-involved youth program, regular contacts correlated with better engagement and sustained outcomes, that consistency is so important. And data-informed clinical practice, regular assessments allow us to adjust intervention as needed based on the data that's received. Data quality, rigorous practices are essential when court, child welfare system, and schools rely on provider reports to make critical decisions. So that's important. And equity consideration is also extremely important. Measuring equity across race, ethnicity, and primary languages and the location is vital and important. And the value of standardizing that information, we encourage the council to collaborate with DOHMH and providers to establish standardized outcomes measurements across all city-funded mental health programs. And the effect that the implication requires that it's fully cost-funded is essential in the 3 areas: data infrastructure. We need to have certain electronic healthcare records, which complements all the Microsoft SQLs and all that server requirements to pull the database and generate the reports in Power BI to provide real-time viable productivity and outcome information to research, staff capacity for data collection and quality assurance, and third, financial needed for training and technical assistance from DOH-MH. Our recommendation is adequate funding for data infrastructure, and the reporting will demonstrate that smart investments in mental health produce meaningful outcomes for all communities. I'm sure you've heard this throughout. I'm just repeating it, but thank you for your time. I just wanted to make sure we presented and we shared our copy as well.
Thank you so much, and I'm glad you made it in time. Okay. If none of the other folks are here, then I think. Oh, right. Okay, sorry. Thank you to everyone who has testified. And if there is anyone present in the room or on Zoom that hasn't had the opportunity to testify, please raise your hand. And if not, seeing no one else, I would like to note that written testimony, which will be reviewed in full by committee staff, may be submitted to the record up to 72 hours after the closing of this hearing by emailing it to testimony@council.nyc.gov. Thank you. And with that, we are signing out for the year, but starting in January. So thank you, everyone, and happy holidays.